today I'm going to talk about various semen preparation techniques, especially in people with the high DNA fragmentation. So we know that globally over 180 million people are struggling with infertility, around 15% of the population, and male factor is 50% in the cases it is male factor. According to ASHA report published in 2014 and 2016, delivery rate per ART cycle was only 21% and 22%, and sperm DFI plays an independent and significant role in reducing ART outcome. And we know that DNA damage occurs during transit through epididymis due to ROS, which are released from leukocytes, immature sperms, or from dysfunctional mitochondrial metabolism. What we do in IVF and ICSI, we actually bypass sperm selection operating in vivo. In IVF, it is still better because the sperm selection is still little natural, but in ICSI, we totally bypass the natural selection mechanism and we choose the sperm. And so the selection of the sperm with DNA damage when using ART can result in undesirable results, which we're not even aware of while doing ICSI. And it can result in, such as lower pregnancy success rate, increased rate of miscarriage, chromosomal malformations, genetic or other birth defect in the offsprings. Now, so the various semen preparation techniques we have been using traditionally are swim up, density gradient, and simple wash. According to Cochrane Review 2019, there's no difference in clinical pregnancy rate, ongoing pregnancy rate, multiple pregnancy rate, or miscarriage rate between these three sperm preparation techniques. And we know that in swim up method, the recovery count is less, but the quality is good. And both the methods are effective in terms of recovery rate. They comparatively yield sperms with a higher motility and better morphology. But we know that when we are doing density gradient method, it releases a lot of causes a lot of oxidative stress and subsequent increase in sperm DNA fragmentation because of the effect of centrifugation, which negatively affects ART outcome. So people have been trying to use non-invasive techniques for quite some time, and because conventional methods are criticized for harmful effect due to centrifugation, and people have tried various techniques like formation of capillary bridge to select motile spermatozoa, migration sedimentation technique, and microfluidics sperm sorting chambers. But the limitations of these non-invasive technologies are inconsistency in quality improvement, and there's a lack of standardized procedure, which is yet remains to be solved. I'll be discussing few techniques which have been used in last couple of years, like MAX. We're all aware of this technique. Came at least 6-7 years back. The principle of this method is to separate the sperms. Sperms have to pass through a magnetic field, and those with apoptosis, they tend to bind the microbeads which contain certain antibodies, and only in the healthy sperms they are collected at the bottom of the test tube, and then these sperms are washed for the final use. But this is a very lengthy and cumbersome procedure, and of course this machine is expensive too. And this also uses density gradient centrifugation to remove leukocytes and immature germ cells. So this cannot be the ideal method for sperm separation. Then coming to the microfluidics, I have used this device in many of my patients. Many of us must have used. This works on the principle of microfluidic theory. This is the device, this is like the device. There is in this chamber, this accommodates sperms. We put media over here, and these two, and the healthy sperms migrate from here, and they are collected. The healthy sperms are collected in this chamber, and all the dead sperms and the debris are collected in this chamber, and we recover the final washed sperms from here. Now, this enables the selection of spermatozoa with low DFI, no doubt, and they have a higher motility as well. But device only accommodates 65 ml of semen sample. So that is why this device cannot be used for IUI, and sometimes not even good for IVF. IVF when the count is low. Yes, for ICSI, no problem, but then this cannot be universal device for all the other procedures. So third device, this Zymod device, this is designed in USA. I saw this device in Fertivision this year. This is a good device. It has two chambers, lower chamber, then a membrane, and an upper chamber. In this device, the liquefied sperm is put, the liquefied semen sample is put here with the help of a syringe. It is around 0.85 ml. And let's have a look at the video to understand how this works. So the sperms pass through this membrane, come up, and then we retrieve the wash sample from here with the help of a syringe. We take the 500 microliter of a sample from this place. This device is good. This works with a space-constrained microfluidic sorting chip like in a manner. It improves sperm characteristic, including motility and DNA integrity. But there is a disadvantage of this device. When you aspirate the sample from here with the help of a syringe, this external syringe pressure force causes contamination by immotile sperms and the cell debris. And also, this is an expensive device. This will cost you around per device is around 5,000 for a patient. It's a disposable one. So that's the disadvantage of this device. Now, when I was studying basically different methods for the semen preparation. I came across this very recent study. This study was done in Taiwan, and this was about a device, centrifugation-free CAO sperm separation device. The study was about to find out a device which could be simple and which can standardize the selection of high quality spermatozoa. And in this study, it was found that the CAO sperm precipitation device minimizes inter and intraoperative variability and also yields spermatozoa with comparable fertilizing property in a variety of semen conditions. That means normal zoospermia as well as abnormal sperm parameters. So let us see how this works. This device works on the principle of natural principle of sperm motility. This has three chambers. This is the lower chamber, this is the filter, and this is the cover. So it selects spermatozoa within a microenvironment through microporous membrane filter. So the sperm sample is put in this lower chamber, then we put a membrane over it, and this membrane pore size is 10 micron. And then we pour the media over the membrane and cover the device with this cover and put it in the incubator for 30 minutes. Now what happened? The sperms pass through microfilter and they are collected in the retrieval port, which is this one. There are 12 columns in the lower chamber. So sperms tend to migrate along these columns, and which mimics obstacle-ridden path of the in vivo environment. This membrane which you put in between the two chambers, this separates and passively selects sperms from the other cellular or acellular components. So this will work only for the spermatozoa who are very highly motile, and they are supposed to be with the less DNA fragmentation. To understand it in a better way, let's just see this video. So cover, membrane, and this is the lower chamber. We put 1 ml of liquefied semen in the lower chamber. You can see the grooves over here. So we put the semen sample in the lower chamber, and we have to ensure there are no bubbles. This is the membrane filter. So the membrane size, the pore size is 10 micron. We know the sperms are 4 micron, and the WBCs are 10 to 12 micron. They are 12 to 15 micron. So that is how it will allow only the passage of sperm and not the pus and the other debris. Now you put 900 ml of media over the membrane. So it will automatically spread out over the membrane. You cover this. Put the device in incubator at 37 degrees for 30 minutes. At the end of 30 minutes, just aspirate 500 microliter wash sample from this groove. All the motile spermatozoa will be collected here. So this study was done. This was a randomized controlled trial of 76 men who sought ART treatment at Taiwan hospital from June to October 2022. 76 neat semen samples were categorized into, there were 27 normozoospermia samples and 49 non-normozoospermia samples. So the neat semen samples were separated for 3 replicates, and 3 different operators were operating on these samples. Pre-selection and post-selection semen quality was evaluated. The parameters included total motility, progressive motility, rapid progressive motility, morphology, and DNA fragmentation index. So the main results were that the CAO device selects Self-propelling spermatozoa within a microenvironment created by a microporous filter membrane. It involves three pipetting steps: loading semen sample, adding sperm washing media, and recovering the process sample. It was found there was low intra and inter-operator variability. There was significantly higher level of motility and normal morphology was observed in the post-selection specimen, whether it was normosospermia or non-normosospermia. In paired analysis of the advanced semen parameter, the study showed that the CAO device significantly improved DFI from 18.2 to 2.6% for the normosospermia. And also, even for the non-normosospermia, the reduction in DFI was 13.4 to 4.2. So it was concluded that the CAO provides an efficient, non-invasive, standardized, and reproducible sperm separation model that diminishes the variations and ensures sperm quality. But there are limitations of the study as well. This was a pilot study examining the sperm quality improvement, follow up whether this selection procedure would result in a higher pregnancy rate in IVF or IUI or IVF. That is still has to be assessed in the future studies. But there can be wider implications of the findings, like it can provide consistent clinical outcome. This is user friendly. This is not very costly. This is a non-invasive method, and there is a possibility there can be standardization of the sperm separation procedure. Now, it's the same group presented another study in August 2023. In this study, semen samples from 239 were collected, and CAO device was used under different incubation interval, like the device was incubated for 5 minutes, 10 minutes, 30 minutes, and 60 minutes at different temperature, like 20, maybe you can call it a room temperature, 20 room temperature and 37. The sperm quality was assessed in 3 devices. One was CAO, which I described, then the density gradient centrifugation and Zymote device. Each sample was evaluated with these 3 devices, and serum parameters included concentration, motility, morphology, motion kinematics, and DFI. The results were that the total motility and motile sperm concentration increased in a time and temperature dependent manner. So the total motility peaked when the sample was incubated for 30 minutes at 37 degrees centigrade. And in paired analysis, CAO showed significantly higher total motility, rapid motility, normal morphology, and lower DFI. Even for non-normososperm samples, CAO had a significantly better result than the other 2 methods. So I used this device, the CAO, in 15-20 of my patients, and I found that this device was good in patient with the good count, because the recovery count was approximately 30% patients. So if you want to do IUI for a patient with a 15 million count, this device may not be appropriate, because the recovery count would be around 5 million. But the advantage of this device was that this was good for even viscous sample. So actually, when I got convinced about this device was I was doing IVF for a patient, and the sample was highly viscous. I was using density gradient centrifugation. At that time, that device was given to me for testing. I just put that highly viscous sample in the lower chamber, and I was surprised to see the recovery count. So what I realized is this device works only for the highly viscous, even for the highly viscous sample, for which otherwise we don't have any other way to prepare the sample except that density gradient centrifugation. But yes, cost is the limitation. Each device costs around 4,000 rupees. Just to share my experience with this device, this is a sample I prepared for IVF of one of the patients. This is a pre-wash sample, right? And then after using this device, this is a post-wash sample. So you can see it's a highly motile, very clean sample, and the initial count was 117 million, and recovery count was 64 million. Of course, this sample is analyzed through the CASA, which I have right now. So it gives you, a little better morphology thing. So this was my experience with this device. So to summarize, we know that the clinical pregnancy rate following IUI among high, medium, and low DFI samples were, this study was published in 2019. There have been many studies which have showed that the DFI has an effect on the outcome of the pregnancy. Although in IUI pregnancies, high, medium, and low DFI did not have a significant impact in the clinical pregnancy rate. However, early abortion rate was high in these patients when the DFI was high, like 27% with the high DFI and less when the DFI was less. Also, the biochemical pregnancy rate and clinical pregnancy rate in the normal sperm DFI was significantly higher. So we know this has been repeatedly proven by different studies in past few years, and we definitely need a device which can give us sperms with the DFI. So I guess this device probably has a future. Thank you very much.
Thank you, ma'am. It was a wonderful talk. I mean, you have just told us about so many newer techniques, and especially it's the need of the hour with living in such a polluted NCR, where definitely the DFI is going to be very high.
Yes.
Uh, Sir, Brigadier Sir, so would you please share your comments?
Yeah, actually, these devices are good, and the my only concern, when I spoke with these vendors, the pore size they're saying, say it is less than 10 micron, and the sperm size 4 to 5 micron, at the width of the head. So the sperm, doesn't go directly like this. It goes like this. So it will touch the pores walls. And would it cause injury to the, cell membrane? And what will be the effect of that? So what we need to do is, the now such sperms which have got small tears on the, cell membrane of the sperm because of, hitting the pores, would they be good for the IVF, or they would be good for the ICSI, or for both? Because for IVF, they may not be good, but for ICSI they will be good, because there we don't mind even if there's a small tear. It will help us to get the chromosomes out of the head much faster. So that was my question to them, and they could not answer me. I said, ki after the these sperms which have been taken out, anybody has done any research on the electron microscope structure of the sperm head?
So I
So
could
that
not find any studies here.
I also couldn't find. So I asked them. So nobody could answer me that question. And if there is a electron microscope proves that there is a tear on the membrane, so then has anybody done any research? IVF versus ICSI. What is the result difference between the two? Whether ICSI would be better for them. That means we should do all ICSI for these, even if the good sample, we should do the ICSI only, because the torn, the membrane of the sperm head may prevent its entry. The acrosome may, release the enzymes early, so it may not be able to penetrate during the IVF. So these are the two basic questions. But however, yes, it has got a role. We need to study further, and especially somebody who has got a electron microscope, they can study it, and then, and secondly, clinical people can compare the IVF outcome versus IUI. Now say you take PCO, or wherever the eggs are more, half you do the IVF with this sample, and half you do the ICSI, and then compare. But that also may not be possible, because in IVF, in ICSI, we are injecting only into the M2 oocytes, while in IVF we don't know whether they're M1 also. It's very difficult to compare the pregnancy rate, the fertilization rate, I would say. But if after IVF the fertilization rate is very poor, then we can say yes, these membrane injuries could be the cause. But nobody has done research on that. I think that requires further studies.
So in my short experience, what I had done, I found that I had a patient, she was a very poor ovarian reserve, just 4 oocytes. So I prepared the semen with this method, and I did all IVF for all, because the sample was good. It was very viscous, but otherwise the count was good. So all the 4 oocytes were fertilized, and I got good quality embryos. Similar thing I noted in one more patient. So based on my minimal experience, I can only say that the IVF results were good because of the probably the selection was better. But of course, what you are saying, that has not yet been studied.
Yeah. So, tell me one thing. You did uh, 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 this droplet culture, or you did it, the
Group culture, sir.
convention? No, no,
Group
group
sir,
culture is
convention.
one. No, no, the fertilization. You did it in a single well, and you made a
Yes, sir.
drop, and then did the insemination, or you had say 1 ml of culture media with oocytes, and then you inseminated. Because then, the dilution would be too much.
No,
What
sir.
method did
Sir,
you use to fertilize?
sir,
How
I did
you
like
made the
in the
plate? I just wanted to know how you made the plate.
so I did the group culture. In the center well, I put oocytes and accordingly we put the sperms.
So that means about uh, one less than a little
50,000.
1 ml of culture media you must have put it under the oil.
Yes, sir.
So
Yes, sir.
so that means you had more than because per egg require at least 50,000 good motile sperms.
50,000. Yes, sir. Yes, sir.
So with this much of fluid, were there enough sperms you could achieve? You must have achieved it because that is why the fertilization happened.
Yes, sir.
Yeah.
Ma'am,
As far as my opinion, I went and saw Dr. Aruna doing it, and I don't know. I feel as far as IVF is concerned, I've asked many times Dr. Shushma Vaid why she does just simple swim technique. And her thing is that she doesn't want to centrifuge or she doesn't want to do density gradient because naturally just now Dr. Aruna also said that with density gradient there is a release of more ROS is there, and that's why there is some damages there. But in IVF you require very few sperms, so probably it will not be required. I can see the advantage of it is that when you find that the manpower is less to you, it takes away your centrifugation, it takes away everything of yours, and you simple put it and uh, just incubate it for some after some you put media on the top of it, and then you centrifuge it, and you half an hour you just keep it there, and then it is there. So if there's a manpower lack, it's good. Probably it will be good. I have no experience, but I feel that as far as IVF is concerned, in any way the technique which you do is a very simple one. You require any processing with that. But even if you don't want to do any processing at all, then probably this will be good. And as far as the DNA fragmentation test is concerned, I'm probably the training center, and over a period of time, I've realized DNA fragmentation test piece of whosoever is not doing it is missing out something. I've yet to find that on the day of insemination or 1 or 2 days before, if the DNA fragmentation high, pregnancy does not occur. Today we are not giving it importance to it, but tomorrow you have to give it importance. हमारे यहाँ तो 80% लोगों की DNA fragmentation निकलेगा ही निकलेगा.
Yeah, it should become a part of her normal investigation
Yes,
of a marriage.
with their lifestyle changes, with their diet changes, and antioxidant changes, things will change.
And but ma'am, again, the very important point which you also mentioned, this should be done at your own center because I keep sending it to various labs. Unka har bar ma'am normal. They always report normal TFI, and the samples are being sent to Chennai and other places kept in dry ice, and then they report DNA
मैडम
fragmentation.
एक बात बिल्कुल क्लियर, आप सिंपल चीज से करो, हमसे सीखो. Hardly it takes any time.
True, ma'am.
It doesn't take time.
It can be done.
डॉक्टर
It
साहब
can
मैं
be
एक
done
छोटी
in
सी
any
बात
IVF
बताना
lab.
चाहती हूँ. आपने एक एम्प्यूल लिया, उसमें एक डिस्क डाली, 10 मिनट आपने वेट किया. 10 मिनट के बाद आपने लिक्विफाइड 2 ड्रॉप सैंपल ऑफ वो डाला, सीमन डाला. उसके एग्जैक्टली 10 मिनट्स के बाद आपने एक ड्रॉप स्टेन डालना है इसमें, एंड दैट्स इट. इन 20 मिनट्स द जॉब इज डन. फिर तो आपको देखना, उसको देखने के लिए आप आधा घंटा लगाओ या 2 घंटे के बाद करो या 4 घंटे के बाद, इट डजंट मेक एनी डिफरेंस. इट डजंट टेक टाइम.
I think DFI testing and this method of separation would become a routine in times to come.
Sir, already, if you see the WHO book of 2021, it says it is mandatory that DFI has to be done.
It should be done. No, I'm talking in the Indian practice. It will also become a routine for all the IVF centers to do DFI themselves and use these sperm separation techniques to improve the pregnancy rate. And 4,000
Ideal
is not a
will
very
be
high cost.
any technique where you find to pick up sperms which have an intact DNA.
Yeah.
वो टेक्निक बढ़िया होगी बस.
With more and more
I
people
think
using, probably
this is very
the cost
interesting.
will come down.
Small technique, hardly anything is done. You just put the specimen there, and after put a media and you keep it in the incubator. After some time, you just aspirate and use it. कुछ करना ही नहीं डॉक्टर साहब उसमें ज्यादा, ना मीडिया का चक्का, ना सेंट्रीफ्यूज का चक्का, ना किसी चीज का चक्का, और मीडिया भी कम लगता है डॉक्टर साहब, मान के चलिए
मीडिया बस 1 ml मीडिया खाली टोटल,
मीडिया भी कम लगता है. Anyway, it is good to know what all is happening all around, and today I'm happy that from Nova specialization as for the sperm selection was concerned, we are moving on to other things, and there are simple techniques available. Cost is the factor now, but I am sure tomorrow the cost will also not be a factor.
I can tell you.
मैडम आप स्टडी करो इसमें प्रेगनेंसी रेट का बस.
हाँ, मैं अपने पेशेंट्स का देखूंगी मैम,
क्योंकि जब एक्सरे कहता है कि in their study every pregnancy is highlighted, they have given a report of 20, they have given a report of 21, they have given a report of 10-22. They have said the pregnancy delivery rate is only 21 and 22%.
yes
That's
ma'am,
it.
yes ma'am.
India is 100%. madam.
Sir, sir, it is very frustrating for all the specialists. I don't know how it is 100% in India. So,
No, it becomes so embarrassing to tell the patient,
yeah,
to convince them that no, it is not 20, more than 20-30%.
that's true, sir.
सर मैंने तो बाहर एक चिपका के रखा है रिसेप्शन पे, वो
And we also put it outside.
डॉक्टर साहब 100% तो होगा. मैंने कहा देखो भाई आ जाओ मेरे साथ बाहर चलो, मैं दिखा देती हूँ. मैंने पब्लिक में रखा, आपको भी कॉपी लगा रखी है कि सक्सेस रेट इज ओनली दिस मच.
No, we put the cost and the success rate both together, so that
नहीं डॉक्टर साहब बहुत जरूरी है. एक बार वो उठ के सीट से आते हैं ना, जब मैं भी उठ के आती हूँ वो भी उठ के आते हैं, तो उनको लगता है यस शी इज पुट इट इन अ पब्लिक प्लेस.
and especially nowadays.
अदरवाइज जैसे आप कहते हैं कि हिंदुस्तानी डॉक्टरों के तो हर आईवीएफ 100% ही होते हैं, उनका 100% से तो कोई सक्सेस कमा ही नहीं. तो एशरे के है किताब में हमारे 20, 21, 22 में डिफरेंस इज 21 to 22%. That's it.
I do. That's it, yes.
Is Shivani there?
Yes, ma'am, she joined.
Dr. Jyoti, any experience of yours, Dr. Jyoti Malik?
नहीं मैम, एक्चुअली मैं इसी अभी जो दिल्ली इसार की कॉन्फ्रेंस थी, तो आई वेंट टू दैट काउंटर जहाँ वो माइक्रोफ्लूइडिक्स के बारे में दे वर शोइंग. So I spoke to my embryologist. He said he has tried everything. He's a freelancer, so he has tried all these microfluidics and all. But he said swim up is the best, and that is best because there is not much ROS and no sperm damage and anything. And he said even he has tried it, but he did not find much difference. So I am not. As personally, I don't have much experience. So, but as Dr. Sharma sir has said, maybe we can do some comparative studies even in IUI cases, doing a normal density gradient preparation and with microfluidics, and then see how the results differ. So, personally not started as yet with that, ma'am. In
Actually,
IUI.
IUI may not be cost effective. In IVF, we can do it.
In IVF, right?
Because in IUI, otherwise, adding another 5,000 or 4,000 for this thing, the patient may not agree to pay.
4,500 is one test costing, sir.
Yeah. So IVF, if you add 4,500, it may not change the patient. But
Right.
IVF patient will not allow.
Yeah. Yes, sir. I think Shivani has come, ma'am.
Yes, ma'am.
Good.
Yeah, I'm so sorry. I completely missed the date and I have OT from 4 o'clock. I have now 8 cases, so I'm very stressed also. So if I can just start the presentation.